We're recording, right?
We are recording.
Sam Newbury, welcome to the podcast.
Dr Sam Newbury.
Dr.
Just Sam's
Sam
fine,
Newbury.
yeah.
I'll call
Do
you
you get your
Doc.
patients to call you Sam?
Yes.
Yeah.
That's good. That's good. I like that.
I don't like the doctor thing.
Yeah.
Not that, I mean, I do like it. Don't get me wrong.
Yeah.
But
Stuff every other doctor.
yeah, I mean, the communication with people is so much easier just to be people.
When you travel, do you put doctor on your flight?
Passport.
I don't.
You don't.
Oh, really?
What about when they say, is there a doctor on board?
If it's convenient to me.
What does that mean?
Well, actually, this flight, when I went over to holiday in Spain, is the first time I've ever had to get up and help someone on a plane.
What was
Really?
It's an elderly lady that collapsed while going to the restroom. And actually, when I went up there was another lady on there and I said, are you okay? Like, because she was doing something and she said, are you okay? And she goes, yeah. I said, you're a doctor? She goes, yeah, but I'm a gynecologist. I said, you and me both. I'm out. I said, but my wife is an ED nurse. She may help you.
Yeah.
Oh, that's
perfect.
hilarious.
And so I got Belinda and I went and sat down with the kids.
Oh, amazing. Finish your gin. Great.
Yeah,
Life is
finish my
good.
food.
Life is good.
And ended up being a whole hour and a bit saga.
Yeah.
But
there you go.
my wife and I sat on the aisle with this lovely old lady, and it was like we were back in ED again. Our early days. It was fun.
I like that. So you came from ED. Actually, let's say what it is that you do. You're an OB/GYN sexologist. I don't know what that is. I know what the first two are. I don't know what the other one is. But in your own words, can you explain what you treat and who you see?
Sure. So mainly women's health, I'd say that's probably the easiest thing. We do, so obstetrics and gynecology are the main parts of what I do. Obstetrics is largely anything to do with antenatal care or baby delivering, and then the caring for families after that. And then the gynecology is all of the things that you would expect to have associated with women's health, things like pain and bleeding and hormones, PCOS, endometriosis, prolapse, menopause, all that sort of stuff.
Ginormous area.
Yeah, all that sort of stuff in between.
Yeah.
As far as a sexologist, I tend to use the term psychosexual therapist a little bit more because I think sexology has a little vibe around it. So I would say that I'm a therapist. And for me, I do some selective specific psychosexual therapy on patients that I think will value it. But the majority of that is incorporated into my O&G practice. So I did that to incorporate that into what I already did as part of O&G.
Okay. And then just to elaborate on that a little bit, with the sexology part, what is, I guess, an issue that someone would come to you for where you'd recommend that?
Well, I guess on a patient-to-patient, so I mean, part of the reason that I did it was I think nearly all of the things that we deal with in women's health linked to people's sexuality on some degree. So, an example of that would be something really basic, like someone has normal regular periods, but they're quite heavy. They're probably in a relationship, trying to maintain a relationship. They're going through the hormonal phases of that, but they're also losing the week of dealing with heavy bleeding and the loss of self-confidence that comes with that. And how do you deal that within a family and a relationship? And so there is often some advice you can give them around, well, what do we do during this time of the month that still maintains intimacy and around that sort of stuff, kind of that relationship maintenance. Other big things like menopause, libido loss, pain syndromes where people, find it difficult with penetrative sex and stuff like that, where they get really sore down below. And how do you maintain a relationship in that circumstance? The people that I would probably do specific psychosexual therapy sessions for would be probably more pain-related stuff because it takes a lot more conversation to understand why the body responds that way in those circumstances. And then sometimes, postmenopausal stuff would be the other group that I do a bit as well.
Yeah, that's really cool.
And STI stuff, actually. Some people get funny... STIs are a funny disease as far as infections goes. People take it to heart quite a lot. There's a lot of unnecessary underlying stigma around some STIs.
Yeah, that's really cool. And it's sort of, it sounds like you bridge that sort of psychology and the sort of science part of it because, I mean, before you're the first doctor I've ever met or heard of that does sort of both. As a probably ignorant point of view, I would assume that you see the doctor for the actual like sciencey stuff. This is what's happening in the body. And then you get, I guess, referred on and see a sex therapist or whatever to deal with the other side. So it's cool that you're bridging those two.
Yeah, I'd say you'd be lucky if you get referred on, assuming you had a doctor that took the time or suggested that. I think probably what I worked out during my training around the psychosexual therapy is the sexology space is very geared toward a certain population groups. It's very metrocentric. It's very, LGBTQ plus positive, because lots of practitioners get into that because of the relationship they have with gender and sexuality and stuff. So nearly probably 90% of that work ends up in that space. And so I think probably, while I'm no means the best at that ever, there's definitely some excellent people in Victoria that are great in this space. Probably the area that I do is that closer to the medical side of stuff and early introduction. And usually when I give talks on it to medical colleagues, the conversations that I do is how do we introduce this into our daily practice? Not so much about how do I do 12 sessions that are an hour and a half long and do that. I think there are people that are much more suited to that and are very good at it, whereas I'm very much like, how do I kick this process off? How do I do it on a day-to-day basis so really that people feel that holistic care that we're trying to achieve?
Yeah. And I can imagine that it's getting more popular as us humans in general feel a little bit less veiled to talk about sexuality, intimacy, etc. I think, and correct me if I'm wrong, but that sort of boomer generation, it was very much like we don't speak about what happens in the bedroom, but it seems like it's becoming part of the conversation more potentially. Yeah,
I think so, but I think a lot of people like to talk about it if the opportunity arises, and it's not that I talk about it with everyone. Some people don't want to, I'll do some introductory questions and they're clearly not an issue, so it's not like we go there. But I mean, a lot of people I'm talking these conversations with are boomers that, they're boomers going through menopause now.
No one ever asked before.
Yeah, no one really. So actually often the conversation, you have to be able to provide a reasonably comfortable environment so that when you're asking the questions, it's a comfortable conversation like this. You're not, and you kind of come from the understanding that it's no big secret. Everyone's having sex. You're all married in a relationship. You've got kids. It's not a surprise. And so you have the conversation like that. Well, how's it going? Which bits are working well? And I think what the extra training allows me is I can actually give some genuinely good advice around that. And so people kind of leave going, oh, well, that was worth bringing up.
Yes.
As opposed to being like, we're having trouble in bed. Yeah, no, menopause is rubbish like that. Anyway, how's your blood pressure? Those, which is, and to be fair, lots of people aren't trained to have those conversations. And there is a fear from because medical practitioners are humans as well, right? We go through the same emotions as anyone else. And I think there's an underlying fear of not doing that well and making it worse.
So you just don't ask at all.
And thereby having that fear, you don't do it well and you make it worse.
Yes.
It's a funny kind of little
prophecy.
Yes, that's really interesting. Yeah, that's awesome. I want to just backtrack a little bit because I want to talk about hormones specifically. But can we just go back to the basics, explain like I'm 5, because that's about the level of education I have around this topic.
Right.
What are hormones and how is it that it feels like they can govern every other area of the body and just swag around like they can just make us do whatever they feel like doing?
Well, hormone is a really broad term. Essentially, if you're going back to kind of a more molecular level, it's essentially kind of your proteins and molecules that are made that travel through your vascular system and affect different parts of your body. So they're a protein that's used for signaling to create effects in different parts of the body. Generally in women's health, when we're talking about hormones, people are specifically talking about things like estrogen and progesterone. But there are many, many, many different hormones, testosterone, prolactin, thyroid function tests, and all the other ones that, get really more specific actions. Some hormones have broader actions throughout the body and some hormones have more specific actions out the body. And I think to understand hormones, you're never going to understand the full impact of how they all affect each other, but they all affect each other a little bit. Have little links and little crossovers, and some work here and some work there, and some use that hormone to get feedback about this. And so it's this big communication system that's trying to essentially have a positive effect on your body with certain aims. So how is it that they can govern your life? I mean, they have to govern your life. You don't have hormones, you'd be dead. Like the hormones are essentially how you send messages and signal everything. It'd be like, how does the internet work if you can't send people anything? It doesn't. Yeah. It doesn't exist. Yeah. So your body runs off that sort of stuff. So that's why it's meant to govern your life. It's part of the.
It's like a currency in the body.
Yeah. Or it's a signaling pathway. It's like the energy and the messages that tell everything what to do. So they're hugely important. It's just some of them are core stuff that everyone has, and some of them tend to be related to our, gonadal structures around ovaries and testicles, and then they tend to differ a little bit in that circumstance, but not completely. And I guess biologically, a lot of the hormones in a female cycle are around ovulation and your ability to get pregnant, and therefore you tend to have a cyclical nature around it that for people who are having a normal cycle tends to sit around that 28-day monthly period. And during that month, and as I'm kind of dumbing it down, as you say, typically in the first part of that cycle, you're reasonably estrogen prominent. Estrogen is the hormone that is involved or produced during the process of egg development. So then it kind of goes up, and its aim, say, in the uterus is to try and thicken the lining of the uterus up, getting ready to accept an egg. Because the lining starts quite thin after your period, and you want to get a nice cushy cloud-like lining so that when the embryo lands in there, it's got somewhere to implant. So it does that during the first part, and then if a cycle goes well and you ovulate midway through the cycle, then that cyst that you ovulate from turns into a thing called the corpus luteum that then produces progesterone. And then the progesterone stabilizes the lining, but it's what gives you the luteal phase and the second 2 weeks of the cycle, which tends to be progesterone dominant. And then right before your period, if you're not pregnant, that progesterone will withdraw, and it's the withdrawal of progesterone that tells you to have a period and bleed, says we're not pregnant. Go ahead and have a period, and we'll do that again next month. And if you are pregnant, then it maintains that corpus luteum and the progesterone continues, and then progesterone tends to be the dominant hormone in pregnancy.
Awesome. So let's tick off some things just so our listeners understand like the basics. So cycle day 1 is day 1 of your period.
Correct.
Am I correct in saying that?
Yeah.
Awesome. And the first half of your cycle is known as the what phase?
Well, follicular phase.
Follicular phase.
Yeah.
Cool.
Because that's when the follicles are being developed.
Got it. Cool. And then ovulation happens. Ideally, if we have a normal cycle, that's what happens. And then the luteal phase is the second half where we're more progesterone dominant. Typically, that's when most women see, I guess, the negative bias symptoms. Is that right? Like your sort of moodiness and a little bit lower energy.
Yeah, I mean, there's a bit of a metabolism shifts that happens. Well, progesterone has a different effect than an estrogen effect. As I said, it's a bit more of a maintenance hormone than it is a kind of growth hormone. So people tend to feel a little bit more energetic in the follicular phase, and then a little bit more. Not everyone does though, but in the luteal phase. But the classic is kind of PMS symptoms and those premenstrual cycles. Often that actually is not the presence of the progesterone that people have issue with. It's the withdrawal of the progesterone that they have immediately before their cycle. So
that's interesting.
Yeah, most people that have PMS symptoms, the most common time to have that is in that week pre-period. It's not it's not when the progesterone turns up. It's actually when that progesterone starts to
go away,
disappear.
Okay. So progesterone itself is not the problem or the cause.
No, not necessarily.
Okay.
But I will say PMS is not a broad thing. People will have different areas, and so working out what sort of PMS and where it times in their cycle is part of that process.
Awesome. And then I just want to stay on the topic of like a healthy cycle, so we can determine what is known as unhealthy and where like some intervention might come in if someone's having specific things. So with a healthy cycle, and just to be clear, I think as a person that grew up as a teenage girl, we tend to be like, I hate periods. I wish they never came. This is so embarrassing. This is awful. It's a pretty tough pill to swallow when that stuff all starts happening. But to be clear, it is a very optimal and normal function to be ovulating and getting a period.
Yeah.
Like as a woman, we love that ideal tick within a certain time of our life, right?
Yeah.
Awesome. What is because I know cycle length can vary a lot woman to woman. What is the normal variance of a cycle length?
So, I mean, typically we talk about 28-day cycles, and they can, I mean, everyone's going to have a variation, and people will have both variation in length in a normal cycle. So, you know, it could be up to 35 days is probably reasonably okay if it's consistent, although 35 is reasonably long. But if you usually run like 26-day cycles and then you have a 40-day cycle and then, you know, something's happened in that cycle, it's not what happened in the others. But there's not a particular thing that I'd be worried about, but I'd like, you know, under 35 days. And it's pretty rare to get them kind of under 25 days because that realistically means you're ovulating like super early, which just actually isn't enough time for follicles to develop. So that'd be what I just talk about for most people in that ballpark is pretty normal. But it's not just per cycle, it's also like consistent cycles. So some people will have a 30-day cycle and every month have a 30-day cycle. That's totally fine. Some people get a little variation. They have a 26 and they have a 32 and then they'll have a 28. That's also probably fine.
Okay.
It's where you miss ovulations and you go 3 months without anything, or if you're really having more bleeds under that kind of 24-day, then they're probably not ovulation bleeds. There's probably something else going on. You know, people say I had 2 periods this month. Probably wasn't a period. Something else has happened there.
Yeah. Okay. Right. Because in order to have a period, there needs to have been an egg release in that whole cycle. Yeah. Okay. And it's just not really going to happen twice within a
you've what we would say is that's irregular bleeding. That's a bleeding based issue, not a double ovulation, for example.
Okay, cool. And so if somebody, like bottom line, I guess, if somebody is having wild variance month to month, that could potentially be a sign that something is not quite optimal with their hormones.
Yeah. I mean, you use the term healthy and unhealthy. I probably wouldn't phrase it that way. I'd just say, you know, what we would say is in the realm of normal and what's outside the realm of normal. And I'd use that as a standard deviation, right? Like, so human bodies are not the same. People are not the same, are not built the same. Everyone's going to have a little different structure in their system, but some of them will be outside that kind of standard deviation of what we'd expect. The most common thing that will do that is polycystic ovarian syndrome.
Yes.
And in polycystic ovarian syndrome, there's variation in ovulation timing, which I'm happy to go into if you're interested in.
Yeah, please.
But essentially, you skip ovulation, you miss ovulation. Ovulation may never come. It might come sporadically. And so you end up with these very wild kind of period schedules that are very unpredictable and hard to manage. I mean, since we're on it, I mean, essentially what happens in polycystic ovarian syndrome is when we talk about the hormonal stuff that we were talking about before and all these little systems that interlink and connect to each other, they all kind of run in this nice little smooth system. With PCOS, if you get a little muck up in one of those systems, there's flow-on effects to all the others. And so you start to get these little breaks in chains and the other systems stop functioning as well as they are. So PCOS as a condition is usually not just one thing. There's lots of different types of PCOS and there's lots of different places in that chain that you can get that little break. And so when you're managing PCOS, working out kind of what type of PCOS or where are the areas that you can get improvement and stuff in is important.
Okay.
But in PCOS, essentially what happens is there's some feedback loops of those hormones that help develop follicles. And they're not so much about quantity of hormone, they're more about how that hormone is released. And if you have a muck up in some of those cycles, that hormone doesn't get released in an effective way. And so instead of getting that one follicle that develops, you end up getting all, 10, 20 of them that sort of half develop. And you just get stuck in the follicular phase. You're just there for however long. And, a couple of times a year, you might get a surge of hormones that ends up getting you to ovulate. And then you might have a period that would be an ovulatory period. But because you're stuck in that follicular phase and the estrogen has a tendency to cause the lining to grow and you never get to a stabilizing part where the progesterone does its work, actually the lining kind of grows and then it thickens and then it just falls off.
Okay.
And when it falls off, you get a bleed and some people think that's a period. But that's why people get irregular bleeding in polycystic ovarian syndrome is because you might bleed and then 2 days later you have some more and then you have nothing for 3 weeks and you bleed some more.
I've heard people talk about spotted bleeding for the last 2 weeks.
All the time.
But it doesn't mean that you ovulated and you're having that shedding.
Doesn't mean that's a normal period.
Right,
yeah,
okay.
It just means the lining can shed and you can have just that kind of unstabilized endometrium.
Yeah. And the cysts in the title, is it the cysts themselves that are secreting something that is causing this disruption? or are the cysts an outcome of too many follicles building up and then they become cystic?
Yeah, so cysts is just a really broad term of any fluid-filled thing. So they're follicles. They're not cysts. They're not cysts like if someone has a scan and they have a 7-centimetre cyst. That's a different thing than what polycystic ovarian syndrome has.
That's a good distinction because I'm like, just take them out if they're cysts.
Yeah, no, but you'll get up like 25 of them and they'll all just be like middle-range follicles. So you can't remove, and they're still not big. They just have to be more than 10 millimetres. So you can imagine trying to cut all them out of an ovary.
Yes.
You'd destroy the ovary. So actually the cysts are a manifestation of what's happening. They're not a cause of what's happening.
Okay.
And as far as cause happens, so look, if I'd say, I'm going to use probably the more classic PCOS, tends to happen in people who are a little bit overweight. And part of the reason that happens is because fat stores estrogen. And so what ends up happening in that type of PCOS is you get this little external input of estrogen, which confuses the secretion of the stuff from the brain, telling the follicles to develop. So typically what happens is you've got this stuff called follicle stimulating hormone. It secretes this FSH down to the ovaries, and the ovaries start developing follicles and send some estrogen back and says, this is how we're going. We're developing the follicle. We've almost got one ready, and the FSH adapts to that. But when you put estrogen in from somewhere else, the FSH thinks that it's developed the follicles more than it has, and so it kind of slows its pulsatility down because it thinks it's got more estrogen present than what it does have, and so the follicles are all kind of waiting for the FSH to turn up, and it doesn't, and so they just hang out all as a group. So that in that form of PCOS, it's usually that external estrogen that's kicking in, but that's not always the same thing. It can be insulin. And
what about in an athletic population? Because obviously you mentioned before obesity or fat storage. What about if you've got someone that's relatively athletic that might be experiencing PCOS?
So you can still have PCOS if you're athletic, and
from a cause perspective, I mean, because you said like potentially there's some from overweight, but like what could be the cause of someone that, and they've had it from a young age, because I coach a couple of women who have been athletic for a long time and have dealt with it most of their lives, if not all.
Yeah, so you can kind of get normal weight. PCOS is pretty normal as well, and it can come from lots of different places. Come from thyroid, can come from testosterone production.
Is it just that statistically an overweight person is more likely to get PCOS?
I'd say it's the more common form, but it's not. But it's certainly not the only form. And I'm not saying common as in 99%. It's just it's just
there's a correlation.
Yeah. That's just one type.
Right.
But you can get it from like extra testosterone production, and there's other stuff that we don't understand that will contribute to PCOS as well.
Yeah.
So in high performance athletes, it's quite common for them to get some irregular or stop periods, and it's a slightly different mechanism. It looks very similar to PCOS, but when you do some hormonal testing, there's a couple of hormones that are slightly different, and there's a condition called hypogonadism. But the easiest explanation for that is you go into a fight or flight response from your reproductive perspective. And if your body is busy burning up a lot of energy, what it will often do is like, we need to conserve energy, and reproduction from a biological perspective is considered to be not necessary. So they'll just actually shut down the reproductive system while that happens. And it happens with often high performance athletes, and usually physical stress.
So that might be, is that different to, I can't remember the name of it.
Endometriosis.
No, when an athlete has too low body fat. And they lose
similar circumstance. Same circumstance.
And amenorrhea, when like periods stop, is that, are they related?
That's just the term that you're, that's not, that's a...
I'm just trying to sound smart in front of the doctor.
You do sound smart.
Thank you.
That would be like a
and your hair looks great
symptom.
Too.
Would you like to comment on my hair as well?
So amenorrhea would be the symptom, but the hypo would be the cause kind of thing. That's how you use that.
And I definitely do want to get into that as well, and I want to get into the whole area of stopping periods, either deliberately or accidentally, in that younger population. But just to stay on the PCOS stuff for a little while, and disclaimer, I don't have it. I'm lucky enough not to have experienced it. But anecdotally, I've got a lot of friends that have experienced it, and it seems that two things come up with them. Number one is pain, and heavy bleeding is probably the biggest symptom that I hear that they're experiencing. And then the other one is there seems to be, anecdotally from what I hear, a correlation with difficulty conceiving, which makes sense if you're not having a regular cycle. Very, very hard you can't conceive unless you've ovulated, correct?
Correct, yeah.
Cool. Okay, so that makes sense just on a timing basis. If you don't have a shot every month like a normal couple does, of course it's going to statistically take longer. But can we talk about the pain that is anecdotally experienced from people with PCOS, like pain when they have painful periods? Is that caused by so much buildup that then the body goes haywire, or?
Look, pain is actually not a super common thing associated with PCOS.
Oh, it's not? Okay.
No, not in general. I mean,
right.
If you have a slightly bigger ovary, like people feel it'll be a bit uncomfortable if you've got some cystic ovaries. But most of them, when we're talking big, we're talking like, you might get up to a 20 mil ovary. So it's not like, it's still smaller than like an 8-week pregnancy. It's not like a massive ovary
ginormous.
That's filling your whole abdomen.
Okay.
It's just bigger than what an average ovary would be.
Yeah.
I guess where the pain would come with the bleeding is when you do have heavier bleeding and you have heavier periods, you tend to get more clots develop in the uterus. The clots come through the cervix and they hurt. So you quite often have more pain associated with the bleeding itself because of the volume. But that's usually quite separate to say what someone with chronic pelvic pain or someone, usually that's a different separation. PCOS tends to be pain related to the event as opposed to those other things that happen with persistent pelvic pain.
Okay, that's interesting. That's really, really interesting. And I do want to talk about pain as well and what's a normal threshold of pain. But first, can you please differentiate for me what is the difference between polycystic ovary syndrome and endometriosis?
They're not even the same ballpark.
Okay.
Yeah.
Okay.
Yeah.
Awesome.
So I guess what we've talked about around the PCOS stuff is really around a metabolic hormonal issue, and the ovarian part of that is very much a representation of what's happening metabolically, and then the symptoms that people tend to experience or get with PCOS tend to be within those hormonal metabolic symptoms. So they tend to, because of the estrogen, the way all those things get converted, they tend to get more androgens and more testosterone in their body. And so they quite often end up with dealing with kind of facial hair, that sort of stuff, more acne than they usually have. Because of the way their hormones are doing, they quite often find it difficult to get into good weight loss. They tend to find weight gain becomes more common, and that can be associated with lots of different things, including your insulin levels and your sugar management system. And often we do, when we're managing PCOS, working on sugar and stuff as part of that as well, like your insulin function. So PCOS tends to be doing that. And the gynecological aspects of PCOS that we deal with are largely heavy periods. That's probably the main thing that we deal with. And then infertility, as you referred to. And it's worth saying on that note that if someone is having irregular periods, we say infertility is 12 months with actively trying. That would be in the setting of monthly cycles. Whereas with PCOS, if you're having irregular periods, you might ovulate twice a year and you have to somehow magically have sex at the time that happens. So actually getting pregnant with PCOS naturally can be a challenge, but not impossible. So there's also a group of people who feel that they've been diagnosed with PCOS and therefore they get the idea that they're infertile and then they get accidental pregnancies. So you can still fluke an ovulation and you can still get pregnant. So it's not that it stops you getting pregnant. It just means statistically your chances of getting pregnant are lower.
And that's the thing that is causing the perceived infertility, is simply just that. It's just less likely you're just not ovulating. Yeah. Okay, cool. There's nothing else like mechanically or like happening in the body that would lessen the chance of a pregnancy. Everything else given the same weight. So like let's say that timing was perfect and they did ovulate that twice a year or whatever. Is there anything else that makes it less likely for them to fall pregnant?
I mean, you could probably argue that saying that the metabolic stuff, might make them slightly less, people who are in a normal BMI range or who have average fitness and, and activity and low stress, or like they're probably all in that circumstance where they're going to get a little bit more likely to get pregnant, but not always. And I think pregnancy is not always as easy as people think. Like actually statistically, getting pregnant's not that common. A completely normal couple with nothing going on, completely average, their chance of getting pregnant per month is somewhere between 20 and 25%. So that's not actually that high. And over a course of 12 months, about 85% of couples will be pregnant spontaneously. The reason we have the 12 months as infertility is if we did that for another 12 months, you only end up at like 92, 93%. So actually not a lot get pregnant in the second year without any assistance. But like PCOS fertility-wise is actually pretty easy to deal with. You just use some medications and get someone to ovulate. I should say easy medically. It's very challenging as an individual going through it. But, lots of people with PCOS doesn't take that much. And then there's a smaller group that can be very challenging to get to ovulate with high dose medications.
Ovulation, is the hormones you just talked about to take, is that to help them ovulate?
Yeah.
And because like obviously I know a lot of females out there track their periods in terms of, are those tests relatively accurate? Or?
Are you talking about the LH testing?
Pee on
a stick and it'll give you a smiley
so
face.
That's a luteal hormone testing. I generally don't recommend it.
Okay. For heartbreak reasons or too much headache or?
They're costly and they don't help.
Okay.
Because I can tell you you're ovulating if you have a regular cycle. If you have a 28-day cycle, I can tell you you're ovulating day 14. I don't need a stick to tell you that.
Yeah.
And I can tell you when to have sex, and you have sex from day 10 to day 16 every second day. You're going to be fine. You're in the game.
That ovulation is about 24 or 48. Like the period that you can get pregnant, if you're having sex every 48 hours, that's all you need to do.
Yeah, well, sperm pretty consistently lasts about 5 days.
I was going to say it sits there for a while, doesn't it?
They can last up to 7.
Yeah.
3 to 5 is pretty common. So for most people, I just say every second day. If you start doing it daily, you'll hate each other. That's the problem. It's actually not that great.
Can confirm.
Yeah. It becomes very functional. So second day works well. I'm okay with third day. Your early day 10 and 12 are probably your best two. If you we're in that position where you only had the option, probably day 10 and 12 are your best 2 days to give it a go. But also, if your last time you do it on 16, you actually will pick up quite a late ovulation then if you end up, something happens that cycle.
You're covered. Every second day you're
kind
covered.
of covered pretty well.
And then just to go back, this is fascinating, but just to go back to the endometriosis and how that's different from polycystic ovary.
I think you're better off talking about endometriosis if we're going to talk about persistent pelvic pain.
Okay,
that's
good.
It's in that category.
Okay.
It's not to do with.
So just to confirm, polycystic ovary doesn't cause endometriosis. Those two conditions don't interact in a way where
different ballparks.
Different things completely. Okay.
Look, probably no. Look, I'd say there's. Probably the analogy that I would say is it's the difference between having a sore hip and a sore ankle. They're completely different spots, different things, different mechanisms. They do live on the same limb. There is maybe some interaction, but you would treat them differently. Yeah. If that makes sense.
Yeah. And if you see someone with polycystic ovary, there's no little flags that go off in your mind that is like, oh, this person might be a little bit more likely to have endo. Let's explore that. Nothing. Just, okay, that's good to know. That's really good to know. So pain then. How much pain, and it's hard because pain is subjective, right? But, anecdotally, you hear of women that have extremely painful periods, can't go to work. Lying on the floor, heat packs, all sorts of things, whatever, right through to someone like myself who's very, very blessed and I get pretty minimal pain. I'm just an angry, awful person for a little bit and, people in my life.
That's like 32 days of the month.
Correct. So not much change.
28-day cycle, 32 of them usually.
Yeah.
Not much change there, let's say.
There's also not 32 days of the month. That's how bad she is.
For our listeners and, anyone that has a uterus, how much pain is normal on a monthly cycle basis?
I can't tell you that. For the first statement, pain is subjective. You'll have a lot of people say I have a high pain threshold, and usually my response is, how do you know that?
Yeah.
What is it that you've experienced?
As a doctor, you definitely don't.
Well, no. Some people do.
Yeah.
And we've got a really good, labor evidence of how people manage pain differently. We see a lot of people go through pain, and people definitely have different abilities to manage it. But so much stuff plays into your ability to manage pain is that I think you can't say I have a pain threshold. Today, at this moment, I might be good at managing pain. In an hour, I may not. In 3 days, I may be terrible. So in order to manage pain really well, you generally have to be in a very strong psychological state and you have to have good reserves and you have to be largely positively mindsetted around dealing with it.
So life stresses are going to impact it, lack of sleep, everything.
All of that will impact your ability. And the classic thing is you can have someone that will go and they're playing footy and they'll take a massive tackle, big hit the ground, bruised ribs, get up, keep playing footy. You walk around your house, you kick your toe in the middle of an argument and you think your foot's going to fall off.
Yeah.
The impact is largely different, and yet one of those is positively geared in a good mindset where I get up and crack on with it, and that they can manage that pain very well, and the other one's negatively geared in the setting of being
That's
stressed.
interesting, and it might come down to the expectation too. Like if
Definitely,
when you're playing footy, you're expecting it, same like you're obviously like right in there with labours and things like that, and you often hear professionals talking about like managing the expectations prior to labour, and that helps that pain threshold.
Yeah. So it helps a lot. And I think when you're talking about period pain, what's normal is I think over time our acceptance of pain has changed. I think probably people have always had painful periods, and that's just a period. Like there hasn't been alternatives or options around it, and so that they just kind of dealt with it. But things like the persistent pelvic pain syndrome and stuff are picking up now, and because of our
what is that? Because we've mentioned that a couple of times.
Persistent pelvic pain syndrome. So look, I think. I'm deciding how controversial this statement is. I think endometriosis gets too much limelight.
Okay.
Endometriosis.
Because I've heard of that and I haven't heard of pelvic.
Yeah, endometriosis gets very... it's a buzzword when it comes to stuff around pain, and it gets blamed for a lot.
Yeah.
And whenever you look up endometriosis, you'll find any symptom that someone's ever experienced will be tied to endometriosis.
Yeah.
And then the next thing you'll say, but some people have some of this and some people won't, and some people have endo and no pain, and some people have pain and no endo. And a logical person would go, well, is it that connected?
Yeah.
Like, how much actually is this connected to endometriosis itself? But endometriosis is what governments put policies on, and endometriosis is what people drive to look. That's a diagnosis they look for to help explain what they're going for, and that's the identity that they tend to tie themselves with.
Yeah, gravitate towards it.
But actually, when you're managing a person face to face, endometriosis is not what you're managing. Their symptoms are what you're managing, and for most people, what you're managing is pain. And pain actually gets caused by a huge realm of things, not just endometriosis. And if you are so heavily endo focused, they will miss their ability to manage their pain through other ways because they just want you to do a lap and sort the endo out.
Yeah,
because the expectation
and to be clear,
is
what is endo? It's a physical manifestation of like, what is it?
Yeah, look, I'd say so. I guess there's some stuff we know about it and some stuff we know less about it. So essentially, at its core, it's where you get kind of cells that are reasonably similar to the lining of the uterus, and they end up inside the pelvis on the surfaces of the pelvis. And the pelvis has this lining called the peritoneum, and one of the peritoneum's jobs is to tell you when something's going wrong. Like if you have a ruptured appendix, it senses that infection, it sends you pain signals, and it says, you need to go see someone, something's going down here. And so if you get some of those cells on the lining of the peritoneum, and then let's say the next cycle, some of those cells kind of stick there, the next cycle, you get the withdrawal symptoms. Some of those cells go, I'm trying to withdraw, and that causes the peritoneum to go, hang on, something's going on here, pain signals, something's going down.
So you can physically remove, people get that physically removed.
Yeah, you can physically remove it.
Yeah.
But there's a lady in Victoria, Susan Evans, who's excellent with this. She does a lot of endo stuff, very intelligent. And I was actually at a talk with her the other day. She's got excellent perspective on all of this. But we had this discussion. She had this discussion around how we should look at pelvic pain and endometriosis very differently to how we currently manage it. And I think the current way that, and that's why I use persistent pelvic pain, because that's what I want. That's what I think the focus should be on. It's on the pain, not on the endo. And probably what we know is that people who tend to have persistent pelvic pain probably have some underlying autoimmunity.
Is the definition of specific pain like once a month or weekly, or how do you put someone in that category?
So it wouldn't be once a month. It'd be someone who had it persistently.
Yeah, okay.
There's a definition that over the last 6 months you had it for more than 50% of the time, something. I don't know the actual definition, but it'd be something like that.
Yeah.
So in that circumstance, so you've got this kind of, people probably have this underlying issue of this kind of, maybe autoimmune, maybe like inflammatory issue.
Yeah.
And then through repeated insults, they start to get sensitization. So that repeated insult can be stress, it can be periods, it can be injuries, it can be bowel issues, it can be bladder issues, and what that does is she's got this lovely diagram that links into a few ways. So that can kind of send inflammatory cells down to the uterus. So when you do have a period, there is an inflammatory aspect that happens in the uterus, and then you get painful periods. So that would be once a month type pain. Yeah. And that may be that inflammatory aspect. Typically what should happen, so most people in a normal cycle, when they have a period, blood will go out the tubes and it'll end up inside the pelvis. In a system that is functioning normally, your macrophages and your immune system will clear up all those cells. Like it'll sweep it up and say, I'll get that. And none of it will stick, right? Because you've got a good functioning immune system that removes those cells. But people who may have a slightly dysfunctional immune system where that is not working properly aren't able to clear those cells enough. And then they start to develop and then they start to cause endometriosis because that's what endometriosis is. It sticks and it grows. And then that endometriosis becomes one of those recurrent stimulators that then causes the rest of the effects. And the rest of the effects tend to be a more systemic inflammatory autoimmune issue. So you'll notice lots of people that have endometriosis do often have mood issues. They have fatigue issues. They'll have IBS-like symptoms. They'll have maybe bladder irritability. And then there's the neuromuscular pain syndrome, which actually contributes to way more of persistent pelvic pain and what people call endometriosis pain than people expect. And actually the pain from endometriosis is probably a reasonably small subset to the pain that someone is experiencing if they have endometriosis.
So it almost sounds like it's full body inflammation to a certain extent.
Yeah.
So then with that, when you're categorizing people to go, okay, this person's starting to lean towards pelvic persistent pain.
Yeah.
What are the symptoms that you're looking for? Like like heaviness when they're walking around, discomfort in joints, like?
No, I mean, I guess that theory largely comes because we know that other systematic inflammatory conditions are more common in this group. So people are more likely to have fibromyalgia, they're more likely to have rheumatoid arthritis, they're more likely to have those sorts of things.
Big things.
Yeah, so reasonable things that once they, and that tends to link into people having a little bit more endometriosis and that sort of stuff as well. So that's where that kind of systemic effects. From a gynecological perspective, usually we would get someone referred to us with a particular issue.
Specific,
but this large conversation because lots of people now, and just because of the way social media works and functions,
on the internet.
They see something, they come in and their expectation is, I want to know if I have endo and I need a laparoscopy. And so a lot of the counselling that comes from that now is very much like, you may or may not have endo. Endo is actually not what we're trying to manage. So you got to go back. So what are you experiencing? Is this what you're getting? Is that what you're getting? Work it out and then you have to have this good conversation around, well, look, these are all of the therapies that we're going to try, of which a laparoscopy for endometriosis may or may not be part of. Yeah. I wouldn't say last. Okay. I don't think it's a gatekeeper thing.
But you've got a few other things to tick off first.
That's right. And while operations generally go very well, sometimes they don't, and some people will go through an operation and they won't get any improvement, and they're probably the hardest group to manage if they haven't been counselled properly.
No expectations.
And this is so important too, because I think what you in your specialty battle with is, and this social media kind of wave, there certainly is a big I guess it's spoken. There's a narrative there that doctors are not listening to me, that I have pain. They're not believing. They're just saying, oh, it's normal period pain. Or like if I'm going like, oh, I think I have endo, and I come to you and it's not what you're saying. If you're not counselling me properly, or it's not landing with me properly because I've got a bias, what a patient might be hearing from that is like, you just don't want to check for it. You're just not believing me. There's like this medical gaslighting term that gets thrown around. So I imagine that's really tricky.
Yeah, it is. And look, I mean, some of that is true, because we have, endometriosis is only relatively new over the last kind of 30 years. So there are people that have come through the system where they have been told that, or there have been late referrals. And often people see conservative management as medical gaslighting. So, for example, you have a young person who comes in with pain and they say, a GP sees them and says, yep, I think you've got some pain. Let's start you on the pill. They get really good pain management. But this idea of like, they tried to mask my pain by starting the pill, it's treating the pain. There are medical ways of treating pain. There are physiotherapy plays a huge role in pain management. And so that's what I'd say. They're conservative, non-surgical ways of managing pain. But to get buy-in from a client around that, they have to understand what you're trying to achieve. And that takes time and that takes counselling. And that's probably where I think the remuneration for medical services, like GPs in particular, is set up for like 15-minute consults, 20-minute consults.
That's what I was going to say. Is
100%.
I feel like if you were to say, put yourself and a GP in the same room, the training that you've got and the training the GP's got, it's like, I got 400 patients I got to get through today.
Yeah.
What my best thing is to figure out the solution that's going to get you out of pain right now. So
yeah, well, I mean, there are plenty of GPs that are really good at this, but in order for them to be good at it, they have to remunerate their time. If they're going to spend 30, 40 minutes with you, then they're probably not going to be a bulk bill GP.
Yeah.
Right? They're going to be someone you have to pay. A women's health
GP would be that way. She would spend a long time with it, and you pay the good money for it.
You got to go there.
She's also backlogged.
That's the problem. And then it's, what we were saying before, 8 months before you get into someone, because that's the quality of care that they're providing.
Yeah, and look, if I suspected, let's say, that I have endometriosis, it would take probably how long we've been talking now for me to go, okay, I understand why it is that you're not straight away going to refer me to get a laparoscopy? Laparoscopy, and like check for it, basically. Whereas like if you had 15 minutes to say like, hey, we're not going to do that first. Bloody oath, I'd be like, just give me what I want. Yeah, I waited 6 months for this appointment. Just give me what I want. I think I have this. I've done my research.
Yeah.
Like, why are you standing in the way of seemingly like getting down to the issue? And then I think there's an interesting probably disconnect that occurs because from what you're saying, and it makes complete sense. It's like actually the pain is the issue, but what a patient might be hearing is like, why are you focusing on the pain? Let's focus on the cause. I think it's endo. So those two things like logically are very hard to, I imagine, to get across to a patient, and then layer in that they may have been waiting months for the appointment in pain.
Yeah.
And there's a lot of layers to, I guess, that buy-in, isn't there?
Yeah, and that's also hard too, when you because when you're going through the months waiting for the appointment, you are on social media and there's lots of stuff on social media like there is about, you get your lap, get a cutout, all this sort of stuff. And so when you then turn up to the specialist, they say like, we'd like to do some more conservative stuff and give it more time.
We're going to play with your diet.
More time. You'd be like, they didn't listen to me or that sort of
I've been
stuff.
here for a year, man.
We've done a lot of studies too on like how people communicate with their health professionals, and then afterwards how it was perceived by the health professionals and how it was perceived by the patient.
Such a great session. The patient's like, that guy was the worst.
Yeah. And actually, sometimes when people come out and they say, well, I've told my GP about this a number of times, I've told my GP is not quite how you expect it to be. You say, I've had my periods have been a bit painful in amongst of an immunisation conversation or something else. And you're like, okay, well, take a bit of pain relief. And they get out and say, they just told me to take pain relief. From the patient's perspective, they have brought that up with their GP. From the GP, it was a passing comment that maybe wasn't perceived. So I think clear communication is really good because general practitioners are excellent at managing this, and most of the ones that don't have the experience or skill set will refer on early, and those that do have the experience will usually offer you some like of those other options first. And then by the time people get to us, I mean, the big thing is never to gatekeep surgery and say, I'm not doing that. I'd never say I'm not doing that to people. But realistically, like if you do endometriosis laparoscopies on people that are like under 19, it's a way different disease to try and remove than someone who's 30. Like often it's like dust on a bench. You got to look at it in the right light and you'll see it, but you're not going to remove an entire person's pelvis and strip it just because you've seen a bit of dust. That's not actually the right decision. So then the question is, well, is that the right time to do the operation as a teen? And so generally I would have that conversation with someone and I'd say, look, usually I try to avoid doing it in people who are under that kind of 19, 20 mark. There are times where we've tried conservative stuff and we've got no improvement, in which case, we'll go to a laparoscopy earlier. But generally I would say try and medically manage it, manage your symptoms, conservative stuff first. And if that works, then you save yourself an operation, save yourself all the risk and scarring that comes with that.
Gosh, I think there's so much, and this is a whole different topic, but I think there's so much, pressure or importance in your role on landing a message with the right tone and connection. Like I'm even, as you're speaking, I'm thinking back about my prenatal care with my pregnancies and just how, you know, when you're in that, I don't want to say fragile, but you're in that sort of like the all of the hormones that come with the pregnancy, you're maybe not feeling super
new experience.
Tough. It's a new experience. You might have some complications, which I did. And you're sort of the importance of someone, the tone at which they're even speaking is just paramount. Like I was in the public system for both, so I would often see, my second was high risk, but for my first I'd see a different midwife or doctor every time, and just the difference in like how I would come out of that appointment, and if something's just slightly said in the wrong tone, the spiraling because of how emotionally connected you are to like there's a life in here, this is my family, my baby, like you've got all of these piles on of emotional stuff that sit behind this appointment. Yeah. And for the doctor or someone in your position, it's like you're literally doing your job and explaining, you know, explaining the management or whatever it might be. But if it doesn't land, or if someone in your position, and you're like very, very good, but if someone's not blessed with those skills, I guess, naturally to connect with someone, empathize, etc., or even they're just having a bad day.
That's right. Or they've had 4 extra people put in their clinic because someone called in sick, and they're, you know, trying to squeeze 20-minute appointments into 10-minute appointments. And that all plays a part.
Yes, like I remember and again, I'm going off on a bit of a tangent here, but my the background, my second pregnancy, super high risk. My son has a disability. We knew about it. There was all this stuff. Yeah. And I was I'd had a C-section previously, and my plan was to attempt a VBAC. Mm-hmm. And you know, by the time I got to the end, I saw one obstetrician who said to me something like, so why are you so opposed to a second C-section or something? And it was like just the way she said it. Yeah, it was like I spiraled beyond, you know, I stood outside and I called my mum and I sobbed, and I was like, I'm just trying to do the right thing for and it was just like, looking back now when I'm not in that mental mind frame, I'm like, what's wrong with that question? Like, it's just, you know, I'm sure she was just asking a question like, is it, you know, gauging whether like what is behind this decision, which is completely fair medically. But yeah, it's like, wow, there's a lot of weight on those 5-minute windows that you have with someone in your position that can just completely colour the whole experience.
Yeah, and I think probably we you know, when you're not in medicine, there's lots of stuff you perceive about how doctors function and how doctors work and stuff. And there's some parts of our job that people talk a lot less about. And there's certain skill sets that you don't necessarily know that you have to have until you're in that circumstance. And people who don't go through this don't probably appreciate or understand it. But there are times in your day, like I can be in a birth suite with a couple who've just lost a baby and engage with that family and give them the best care that I can in that supportive environment. Walk next door and be super excited for a family who's just had a baby. Or be in a room with someone that's unhappy because the buzzer's too far away or because the blinds aren't at the right position after having just been in the room with a family who have lost a baby.
Yes.
But I have to be that positive, helpful person for that group of people. Literally less than a minute after I had to be that
60 seconds to
super
reset.
Supportive person. And we do that on a clinic basis, day by day, as in we will see one person who may have a pregnancy similar to yours, where we are managing some things in it, we're gauging where you're sitting at, we're making sure you got the right emotional support, and we're in that kind of counselling mode. And then someone who's got a completely different thing. Their partner's abusing them mid-pregnancy, they're on drugs, they're smoking alcohol. I've got to be there for that person. The next person's excellent pregnancy, they're having great times. Oh, little baby, super cute. You know, it's just that is
wild on your nervous system.
You know, trying to work out how you do that. And some people are better at it than others. So yeah, sometimes there'll be days where you do mistone. There's not a lot of professions in the world where the tone in which you say something carries so much weight.
Yes.
You know what I mean? There's nowhere else you would be where if I said, I'm sorry, that's it.
Yes.
You're the worst. You've just ruined your day.
Totally.
Do you know what I mean?
Yeah,
And then,
100%.
you know,
And that's actually like literally the point I was getting at. It's like you, and probably, obviously I've never been to med school, but it's just like you get taught the medicine, but and you know, the people that are attracted to medicine might be, you know, because they're obviously super interested in that field, like whatever, but like some people are just naturally better at being able to do that social connection stuff without so much effort.
Yeah.
So when I just think about, you know, words like, you know, burnout and things like that in your profession, it's like bloody no wonder, because if you're someone where it doesn't necessarily especially come naturally, how hard you have to work in each of those different, to pivot in each of those different settings is, have you seen or read the book This Is Gonna Hurt?
Oh, I've read bits of it. I didn't because it's basically my job. And I was like,
that like
it's just a book of my book.
Yeah, I think I read it like 4 times, and they put out a series on it. I just found that like
popular.
Fascinating for someone in your seat. But I did want to quickly talk about stopping ovulation deliberately, or actually that's probably not the right term. I want to talk about contraceptives. Or interventions.
Before we go to there, I just want to ask one question back to where we were before, the last one. Obviously, TikTok's the number one place you want people to get information from. What's the second place? Like if someone was to be like, if someone said to you, I've done my research, where would you have liked them to have gone? Are there books?
Is TikTok actually your answer for
No, I tell you.
Sometimes he tries to make jokes and it doesn't land with.
No, it wasn't a joke. I was like,
you said TikTok was number one. But no, like what, like where do you want?
Look, I'm not against social media as a form of learning information, right? Like because I mean, one of the benefits of what's happened is we've the information age means that, you know, most people can get access to information that we never used to be able to get to. You'd have to go to libraries and books and take you forever to learn the same amount of stuff. So I'm not against the principle. I think what we've lost is the critical reasoning. That's what we've lost. We've lost the ability to critically appraise someone's opinion based on our own experience. We no longer look at something that someone says and go, is that right? What else did someone else say that said that that's right? You know what I mean? Like, is that true? We just go, oh my God, I read this.
Go to the comments on our most viewed, this podcast most viewed reel on Instagram, and like if you, it's rage bait. It's rage bait. They don't listen. Anyway.
Yeah, but I mean, that happens too, right? I mean, that's part of the issue. And because of the way the algorithm works, if you talk about the pill, the pill's bad, the algorithm goes, you want to hear the pill's bad. Here is all the things about how bad the pill is. And you actually don't see the bit that tells you all of the positives for you. And of course, they're not individual advice. So where would, I don't know. It's so hard to actually say. Look, I think your ability to be able to look at a resource and say, this is a quality resource. You know, this is from someone who
That's what I mean, because I feel like your lens, you'd look at it and you'd be like, what is their education?
Yeah.
They don't have anything. They've just done a weekend-based course and they're calling themselves a doula or whatever it is.
That's right. Yeah. Immediately, literally, like if I saw something and someone sent me something, I mean, I'm a highly critical human being by nature. But if someone sends me something, the first thing I do is look at what their education was.
Yeah. Why did you start working with me then?
Well, I figured it was a blank slate. We could really build you from the bottom up.
You're in the trial.
Nice.
No, I mean, kind of medically, I'd look and say, well, where's this person coming from? And, you know, realistically, all of the people with the experience and the knowledge are not in a generation where they're on TikTok.
Yeah, that's what I mean.
The doctors even that you get on TikTok are often like your quite junior, early in their career doctors who are trying to not have to work all day.
Yeah.
And then
they're trying not to be a doctor.
That's right. And my next question is, well, what is your motivations?
Yeah.
Why are you doing this? Because being on TikTok and being popular on TikTok is a lot of is a lot of energy and effort.
Yeah.
And why are you doing that if you also have a full-time job as a doctor? Like, what is your motivation? And there are a group of people who genuinely want to spread knowledge and information, and they do it out of the kindness of their free time, which we're very appreciative of.
Yeah.
And then some of them are trying to look at it as an alternative career
I don't want to be a
path.
doctor. Like, it's an option to
and
go
then
into
also,
surgery.
like, if they are doing it to be popular or to like gain a following, people are smart enough to know that the algorithm likes rage bait and things like that.
Right.
So that
and they
further
pump that stuff up. But to answer your question, I'd look at more like article-based stuff. Like people can get access to research papers.
That's what I mean. I feel like Google Scholar or whatever it is.
Google Scholar. There's a thing called PubMed, which houses nearly all of our medical research, and you can ask particular questions.
Search,
What about Ask Docs on Reddit? Sometimes I cruise there just for.
I don't know. Haven't seen it.
I'll show you.
You don't want to know it,
but okay.
Yeah, it's like a comment section.
There's verified doctors on there though, and they answer people's questions.
Yeah, right. Cool.
It's interesting.
Yeah.
It's interesting.
Yeah.
Continue on. Sorry.
Yeah, so I want to talk about because it's been demonized a little bit. I feel like in some of the circles that I've that I run in or I've had exposure to. But so let's say a teenage girl comes in, she's having periods, they're heavy or heavy by her standards or whatever, but maybe they might be within that range of normal medically. She's having some pain, again, might be in that range of normal, medically normal. It seems as though, I've been in this situation as a teenage girl, it seems as though the first line of treatment, I guess, or recommendation is like, here's the contraceptive pill. This is going to help. Mm-hmm. Now it feels like there's quite a bit of discourse on like, hey, the pill is actually stopping something which is, it's not a real period. It's a fake period. You're not ovulating, like whatever it might be. Can you just talk about that in general now? Where are we at with that?
Yeah, like it's like, I guess when you're talking about the thing is the problem is that for as much information as you have people sitting there saying that the pill's terrible, you equally have as many people who come and ask for help because they're getting pain and heavy bleeding. So, so like, I think there's lots of different ways to manage different things. Yeah. And we would usually, there's some conservative, there's medical stuff and there's surgical stuff. And so people have different options depending on where they are in their life. Conservative stuff is hard and people don't like doing it. That's the realistic thing. Yep. I can tell someone that, yeah, sure, you need to go lose 15 kilos of weight and you need to change your diet. And the thing is they don't do it and they come back in 6 months and they say, well, that didn't work.
Yes.
So if people are genuinely not wanting to use medical management and stuff, there has to be a very heavy conservative effort first. And just like we talked about before, people don't like their doctor saying that. Like we want to say it and we want to give that good advice, but that's actually what people didn't pay and wait 3 months to come and tell me to go do this.
And then you get a bad review on your practice and
but that's
whatever.
The actual those things are hugely important. It's amazing how much good quality exercise and stop eating processed crap will do for your well-being. Yeah.
Ultra processed, as Dr. Tim says.
Ultra processed, which is everything.
Not monster.
And then like starting the pill is a good option because it's effective. It works. It gives people back some quality of life at a time where it's very valuable to them. So when you're looking back to someone who's between that, say, 16 to 20, they're going through school, they're learning how relationships work, they're at risk of unintended pregnancies, they're going through pain, they're doing their maybe VCS, they're working out what stuff they're going to do. If they're spending every month dealing with this heavy bleeding and this pain associated with this, then that becomes a reasonable focus of a very important developmental time. So yes, starting on the pill can be quite effective for managing those symptoms, and therefore they can actually be a more fruitful, successful human being during that time frame.
Yes.
What do you say when people say that that's ruining their ability to get pregnant later? Because obviously,
it's not.
That's what I mean. We had this discussion last night. But what would you say to that? Just other than no.
As that's not.
Yeah. There's no correlation scientifically in the research.
Pill doesn't have impact on your. So part of the issue is like people might have PCOS when they're 16. They get irregular heavy periods. They start on the pill. They get regular periods.
It masks
it doesn't mask. You've used the mask.
Sorry.
It treats their irregular periods and their PCOS right as a management strategy, just like you would a blood pressure medication or anything else. You're using a medication to treat the irregularity, but then they get to 20 and they stop it and their periods are irregular and they say, well, I can't get pregnant. The pills made me not ovulate. Well, no, actually, you've just been on a management strategy that's been effective for the last 5 years.
Yes.
And you've stopped that management strategy and now you're back to where you were.
Yeah. So, okay, let's go to like the basics. Does every pill, how does it work? Does every pill stop ovulation and give you a fake period?
Yeah, that's what I'm curious about. Yeah. Why do you bleed every month? Why does someone that has PCOS that then gets on the pill bleed once a month?
Yeah, so I feel bad for the pill periods that have been deemed fake. You're doing really well, pill periods. You're doing a great job.
You're doing great, sweetie.
Yeah.
So basically, we talked a little bit about the hormone progression that happens where you get estrogen at the start, you ovulate, progesterone at the end, you withdraw from progesterone, you have a bleed.
Yes.
So the endometrium is not a super complicated, the lining of the uterus is not a super complicated being. It's like, yeah, I'll do whatever you want, man. Oh, you want me to grow? Sure, I'll do that.
Yeah.
Oh, the progesterone's gone. I'm going to bleed now. So it's
Now I'm angry.
It's pretty good like that. So what you do with the pill is at the start of the pill, you take a dose of estrogen and progesterone that is the same as you will take all month.
Yep.
So no estrogen dominance growth, no progesterone stabilizing. You just take it the whole month and the body's like, oh, sweet, we've got estrogen and progesterone there. We're not developing follicles. We're not doing anything. We're just like, the hormones are kind of convincing me that nothing's happening. There's just enough hormone there that it overrides what the body's doing and it doesn't ovulate. And then you get to the end and you withdraw from it and the withdrawal causes a bleed.
Okay.
Yeah,
but it's
uterus
not,
is like,
you didn't release an egg.
Didn't release an egg, no ovulation. You get to the end and the uterus is like, oh, there's no progesterone, I'm going to bleed, man. Yeah. That's it. It does. That's all it does. And so it has a period.
Yeah.
So,
and a period is just the shedding of the lining. So it ain't fake because the lining was there and it got
it still sheds the lining of the uterus.
Yeah.
Yeah.
So what is it then that people...
But it's not an ovulatory bleed, which is probably a better term.
Is that why it's less painful?
No. Well, I mean, the other thing about hormones is it also keeps stability throughout the course of the uterus, decreases inflammation in the uterus, and therefore they tend to be less painful. And you don't have to have a period, right? Like because you don't go through the growth scan, generally you don't have a high buildup of endometrial lining anyway, so periods are often lighter. And for people that have pain, generally, the way you might use a period is I have really painful periods. I have 12 periods a year. If I take the pill and I skip the sugar pills and I run 3 back to back, all of a sudden I'm 4 periods a year. I only have 4 pain episodes. If I manage to do 6 months, I'm down to 2 pain episodes a year. Your quality of life improvement is drastically better.
What's the cost of that though? Because obviously TikTok tells me that is awful for the development of a female.
I would say it's awful for the development of a female. Like it's obviously changing the hormonal stuff.
Yes.
Plenty of people on it. People are developing fine. This is new. We've been doing this for like a long time.
Yeah.
We, as if it was me. But, like it's been happening for a long period of time. People develop fine. They got the presence of estrogen and progesterone. That helps all of their tissues. That helps all of their estrogen-supplied vasculature. You're not going through the cycle. The problem is like any medication or just like, as I said, heart medications or anything, they have side effects. Yeah. Some people get side effects to them. Yeah. Some people get some irregular bleeding. They're not quite as effective as that.
Weight gain's a really common reported one, is it not?
Yeah, but weight gain is not necessary. So there's some pills that are worse or some contraceptives that are worse than others. So we tend to find it's a little bit more common in progesterone only types of contraception. So there are a couple of really good progesterone only, and they're actually really good for pain management. And the intrauterine device is one of them. And it just gives a constant progesterone, and that is still a constant signal, but it's a little different. It's kind of telling. It's almost like convincing your body you're pregnant for a little bit because that's the dominant hormone in pregnancy. And so people's metabolism tends to pregnancy gear a little.
Right.
So what tends to happen is they in pregnancy, one of the things that progesterone does to the bowels is it slows bowel transition. So let's say you're pregnant, you have the same amount of food, but because it slows the transition, you can absorb more nutrients out of that. So then people's bowels tend to be fuller, so they tend to feel bloated, and they tend to had more weight because they're holding more weight in the bowel. Yeah. The other thing that happens is your blood volume increases in pregnancy. In the first trimester, it's about 25% increase in blood volume.
Isn't that crazy?
Yes, it is. And so you gear towards increased blood volume. That makes you feel a bit more fluidy.
Yeah.
That
puts literal weight on the scale.
Puts more weight. Yeah. So both of those will put literal weight on the scale. Yeah. And then in pregnancy, the body tends to metabolically gear a little toward storage because it's storing it for the purposes of looking after a baby. Yep. So it absorbs more stuff and then it stores that stuff. So people do put on weight gain. So lots of people say, I've done nothing different and I'm starting to put on weight gain. And I think from a medical counselling perspective, part of the counselling when you're starting those things is you should be doing things different.
Yes.
Yeah. You're going to start the pill. This is going to be good for this aspect of stuff. These are the side effects. To offset those side effects, you need to make some changes that are going to make that a little better.
And you said, I noticed that you said for a little bit. Does that, when, for want of a better term, the body thinking it's pregnant, to use as an analogy, does that then calm down if you've been on the pill or the IUD for a little while, or
people tend to get a little bit better with it over time. Like the IUDs, it's a much lower dose progesterone. So, I mean, the benefit of the IUD, people will still often ovulate on the IUD because it's really, with the IUD, what you're trying to do is you're trying to limit all of the systemic side effects and just deal with the uterine part. And as I said, the uterus is simple. Is there progesterone there or not? And so if you put progesterone in the IUD, then the lining is just like, well, just chill, you know.
And for the listeners as well, the IUD is a literal device that is sitting inside your cervix.
It sits inside the uterus, not the cervix, so it's higher up. But it's a little T-shaped device. It's got kind of a plasticky and a tiny little bit of hormone in it.
And so it's delivering the hormone straight to the zone rather than a pill, lining, which is, like you said, systemic which is has the potential to cause some more side effects.
Well, yes, but it also has a potential to cause more benefit. Because if someone is dealing with other kind of hormonal issues like acne and hirsutism and they're looking for hormones to help offset the management of that, the Mirena won't work with that because it's localized. You need to then look at pill-based stuff. And the Mirena also doesn't have estrogen in it. So sometimes people's linings get really thin and then they can get irregular spotting and bleeding, and actually going back on a pill or having some estrogen again can help offset that. So it's not a straight line for everybody. And different pills have different estrogen and progesterones in them, and different people's bodies will match with them differently.
Right.
So often, you know, someone they'll start on a pill and they'll be like, the pill didn't work for me. You know, we have probably around 25 to 30 different types of pill. And so actually, I wouldn't say the pill didn't work for you. I'd say that pill didn't work for me. That particular
pill. Yeah, it's kind of like an antidepressant. It's like you might need to play a little bit before you find one that works with your body.
Yeah, that's right. And weirdly, the other thing is lots of people come off the pill and, you know, they might have been on it for 4 or 5 years and I feel so much better, like when they come off it. And as I said, the benefits around the stability throughout the course of a cycle is that you get stability over bleeding and pain management and that sort of stuff. But lots of women are used to going through variation in their cycle. They're used to having a really good half of the month and then maybe not as good second half. And so when you stabilize that, it feels a bit blunted. It feels like a bit tampered or something.
I was going to ask you about this, and it's a selfish question because the test subject is myself. But I've got an IUD in after my second child, and my biggest, I guess, worry about it was my athletic performance because when I'm around ovulation, I'm freaking bulletproof. I know that's when I can push the higher end numbers, PBs, things like that. We'll often change the programming. Well, Chris somewhat agrees.
Really loosely
like,
there.
That is when I'll be like, I know I'm ovulating. I'm going in to do my high end training. My pain tolerance is awesome. Like whatever. So that obviously the flip side of that is potentially that premenstrual stuff where it goes the other way.
Yeah.
But that was one thing that I was like, I actually don't want to lose that little bulletproof window that I have every month.
Yeah.
My question to you is with IUDs and like, how do you know if you're still ovulating?
So typically people will still get cyclical symptoms if they're ovulating. Like you'll still get your bulletproof feeling and you'll still get your premenstrual. You just won't bleed. Yeah, or the periods will be way later. Yeah. Whereas if you're pretty consistent throughout the cycle and you don't get any crampy period pain and stuff, you're probably not.
Yes. Okay, cool. And is it right in saying that like if there is a bleed with an IUD device in, does that automatically mean that I have ovulated, or is there non-ovulatory bleeds?
You can still get some irregular spotting and stuff.
So there's no way to really know if I'm ovulating or not.
I mean, you could test it if you were really keen to know.
I don't care that much.
But it depends on what you're trying to achieve. But actually, like Mirena's aren't a bad choice for athletic performance because of the lower systemic hormone. And depending on what you're using it for, if you're using it for bleeding control, then a Mirena is probably a good choice. If you're using it for contraception, then Mirena has a little baby sister called a Kylena, which is like a millimeter smaller. It's very little, but it's got less progesterone in it. It doesn't control bleeding and periods anywhere near as well, but it is less likely to stop you ovulating. So if people are wanting contraception and a better limited input on their body, then the Kylene is a good choice. But if they're also wanting bleeding management, which you find people after having babies all of a sudden tolerate periods less, and they'd prefer just not to have them, then a Mirena is probably better at that.
Sometimes after pregnancy, periods.
They change. Like that's the other thing.
We've had a bloody enough by that point. Seriously.
Yeah, like, and bodies are biological. Like we can't, like, can't expect them to work. Yeah, you can't expect them to work.
She loved it. She was like, this is the best it's ever been. And then it's changed every time, every baby essentially.
That's right. I mean, you can't, and it's no surprise, right? Like you take an organ that's like this big, you stretch it out to this big, you plant a placenta on it and you change all the vasculature and the blood flow in and you peel that placenta off. And how would you expect it to be the same?
Yeah.
Exactly.
Sounds like something from a movie made. Aliens.
Had enough.
Aliens.
It is aliens.
Yeah. And so is there sort of like a, I guess, gold standard process that you go through when recommending a contraception? Or is it more around that education piece? Like, what is it that we're trying to treat here? Is it for contraception? Is it for bleeding? Like, what is important to you? Like,
definitely.
Those are all the things that not now, but like that you'll look at to determine which contraception you'll recommend.
Yeah, what your choices are. So you just go through the history and say, what is it that you're trying to achieve? And someone will go, I just want some contraception. You're like, sure, then you ask a bit about the periods, do you have any, issues with acne or hair growth or anything? And you just go through those kind of things that you might get positives and negatives with. And then you'll start there. If I'm starting like an oral contraceptive to start with, I will generally just start on a cheap PBS pill because they're cost effective and they're available.
Yes.
So usually, unless there's specific symptoms that we're looking at managing, most of the time, I would just go for the one that you could walk into any chemist and grab, and it's going to cost you $5. And that's usually where we start, because if that works, that's an easy option. If it doesn't work, then you can start to move on to the ones that are off the PBS, and they tend to get closer to $30 a month, $30, $40 a month, which for teens is a reasonable investment. So, that's kind of how we do it. The IUDs are becoming far more popular in young people now, because they get really good quality contraception and bleeding control over that time of their life where they really don't want unintended pregnancy.
Yes.
And once you take it out, you'll have like a period the next month. So minimal delay on.
Changed my mind on so much in this conversation.
Have I?
Fully, yeah.
Get off TikTok, man. Talk to a professional.
Yeah, well, I thought I was talking to professionals years ago when they were telling me the harms of it. And like this is the guy I talked about when I was going to a gym doing blood work and stuff like that. And they're very health positive, I suppose, all natural stuff. And obviously my mind has changed over the years anyway, in just seeing differences in certain people on hormones, whether it's females on estrogen, males on testosterone, at certain periods in their life, post-surgery. I have a friend that had a testicle removed and was using testosterone as a replacement, and the quality of life difference and all that type of stuff. It's just, what's fascinating to me is it has felt, maybe through the information age, that, and might be my algorithm, that the pill's a bad thing, and that the consequences to it are great and they last a lifetime. Even though, but what it sounds like you're saying is that, like, through that, because I would have said half an hour ago, my kids won't take the pill. But now, like, some of these positives are like, man, it doesn't actually sound that bad.
Well, when you've got someone that's trying to go through grade 12, and they are taking, a couple of days off school every week, every month, and they're laid out and they're double layering pads and that sort of stuff. Like, that's not fair.
Yeah.
Do you know what I mean? Like, and it's just one of the strategies to do that. The difference with that young group of people is we lose all of our surgical options, because all of our surgical options, stop you getting pregnant largely. So you are really limited to. Now, that's not to say that the information that you were given before around the importance of good nutrition and the importance of good supplements, all of that stands very true. Yeah. And I think that needs to be a cohesive discussion around that. It's just that you get different populations of people. So there is a group of people who are very heavy on that I would see who would choose not to be on the pill. I'm fine with that. It's just an option that we're offering. But there's also a lot of group of people that come in and go, I want this, I want this sorted out now.
Give me the tablet.
And the other thing I always find funny about hormones, and this is people don't like the pill, like often, don't want the pill, They go through all their life.
Give me estrogen.
They hit menopause and they're like, where's my HRT?
Yes.
Yeah, 100%.
I want it back.
Yeah.
Damn TikTok.
100%.
It's so popular now, right?
Yeah,
HRT is super popular.
100%.
So, and I might be jumping around and stealing the show a little bit. The two biggest times I've heard that females have really big hormonal changes is post-birth and menopause. And they're like, they're
first starting their period.
And for starting their period. And what has clients of mine and stuff like that, they've talked about post-birth seeing pelvic floor physios, and some of them have suggested estrogen to help with whether it's prolapse or helps with certain things like that. And my gut feel when hearing these things a couple of years ago was like, oh, like, are there other interventions? But the people that have been on these things are like, it worked really well.
Oh yeah, vaginal estrogen is the best.
Yeah.
Yeah.
So yeah. What's the
Hell yeah, man.
Yeah, man, do it.
Yeah.
Everyone.
For me?
Yeah.
Suppositories of estrogen post-birth. Is that what we're talking about?
So sort of, but also menopause. So I guess we're talking about vaginal estrogen. The first thing I'd say, the hormonal change, probably pregnancy is the biggest challenge that a female body will ever go through.
Yeah.
Physiologically, muscular, all that sort of stuff. It's a huge challenge for the body to go through.
Understood, yeah.
And then afterwards you get the repercussions and stuff of it, right?
Yeah.
Can confirm it's cooked.
Yeah.
Yeah, it's challenging. And then again, like we tend to be if we do nothing, people will have vaginal births. Like that's general advice. So cesarean section is there as an option to manage complications. And if we do nothing, people will generally have vaginal births and hopefully well. When you're counselling around vaginal births, the one of the hard things to talk about and discuss is prolapse and vaginal trauma.
Yeah.
Because it's almost seen as you become an anti-vaginal birth person if you talk about any of the downsides of vaginal birth, and things like urinary issues and prolapse and vaginal trauma are part of that.
Yeah.
And yet when you talk to the premenopausal or menopausal population, which is usually when that becomes a problem, it doesn't become a problem until you're after 50. And so people get to 50 and go, why didn't anyone talk about this when I was having babies? I might have made different choices. And so it is hard to, and there has been
a fine line.
This idea around, consenting to a vaginal birth, which sounds stupid, and I don't think it should be done. But the principle there is like, do people actually have an understanding around the choices?
Are you saying that potentially someone can have, and I haven't experienced a vaginal birth, 2 C-sections, but are you saying that someone can have a vaginal birth, not experience a prolapse in the neck, like straight away, but then when they get premenopausal or menopausal, then the prolapse? Oh, definitely.
That's what happens for most people. Yeah. Most people don't have prolapses.
And that's
the whole
because
time.
of a drop in estrogen.
Yeah. So I would nearly argue that pretty much anyone that's had a baby vaginally has some degree of prolapse, right? But the vaginal sensation tends to be in the lower third. The upper 2/3 you don't have a lot of sensation in. So you will get vaginal wall laxity just in the top part of the vagina that, like, you don't know it's there. It's not there. You don't know, right?
Yeah.
Like, so if some people, I should say just a little caveat, some people have really bad tissues that do get quite bad, their muscles and their nerves and stuff stretch a lot more, and so they tend to get it earlier. But then what helps manage that is one of the big effects that estrogen has in your body is around blood supply.
Okay.
And of course blood brings all of the nutrients and it brings all of the oxygen to tissues, particularly things like skin, muscle, ligaments. And so if you get blood supply into the vulva and the vagina, then it's easier to like rehab and get, say, perineal muscles working well. The skin integrity is better, so it's better at managing kind of trauma and friction, which comes with sex. And then the ligaments maintain their support a little bit longer. When you go through menopause and you lose the estrogen, the muscles start to atrophy, the ligaments start to atrophy, the skin starts to thin, and then all of the intra-abdominal pressure exerts its weight on that area. And so prolapse tends to turn up after menopause for most people.
And is this specifically for women that have had babies vaginally, or is that all
Definitely
women?
More common.
Yeah. Okay.
You can still get it sometimes after a cesarean section because, prolapse is essentially a pressure issue. You increase pressure in your abdomen, the pressure is going to want to go somewhere. It's either going to go up through and get hiatus hernias, through your tummy, it's going to give umbilical hernias, or through the vagina and rectum, which gives you prolapse type symptoms. So it's just like, in the more pressure you have in your abdomen, the more chance you have of getting prolapse. When you do pelvic floor exercises, which are an excellent thing that people should be doing, the only thing I'd say is contraction is as important as relaxation when it comes to pelvic floor.
This physio that was working with this client she was working more on the relaxation than the contraction stuff.
Yeah, and that's like, because people do get really tight pelvic floor.
And that's why it's not just a case of like do Kegels, because it's individuals.
Yeah, because it causes similar symptoms. But that dynamic nature of the pelvic floor is important. But really what it does is support the lower part of the vagina. It won't lift the top of the vagina back up. The pelvic floor won't lift the top of the vagina back up. It'll just support the lower part. And because the feeling of prolapse is often like an openness, dare I use the word, kind of gaping feeling, it restores tone to the vaginal outlet, and that helps that feeling. So I don't get that feeling anymore. I have a feeling of strength around the perineal and pelvic floor, and therefore you've managed the symptoms, and that's fine. That's good prolapse management to get some sort of symptom management.
So potentially then some estrogen intervention
Yes.
alongside the pelvic floor physio stuff.
Yeah, so it depends on what you're doing, right? So once you have your progesterone dominance through your pregnancy, if you're breastfeeding, you generally maintain progesterone dominance, right?
Okay.
So you'll continue doing that until your periods kick back in when your estrogen starts again. So you are low estrogen, which means you are missing that bit of blood supply that comes to help with all of those healing factors in that recovery period.
So estrogen stays low while you're breastfeeding?
Yeah, it does.
Okay.
Yeah, and then you don't want to take systemic estrogen because it'll stop your breastfeeding, right? So you want to maintain breastfeeding.
Yes.
So localized estrogen in that setting can be beneficial.
Okay.
In that it just brings that, because very little of the vaginal estrogen gets absorbed into your system, to nearly arguably none. So it works quite well, doesn't interrupt your breastfeeding, but can give you...
Is it because it just stays so local?
Yeah,
Okay.
that's right.
It's kind of like the IUD stuff again.
Similar
it's
sort
like
of thing,
localized.
but even more localized than that.
Right, okay.
Yeah, wow.
And then similar things through menopause. I mean, menopause is essentially your body withdrawing from estrogen.
Yes.
And so if you're trying to manage vulvovaginal issues in menopause, which is usually like skin thinning and skin irritation and weaker muscles and that sort of stuff, it's very good at managing that.
Yeah. And so why then has HRT, so obviously for those reasons, menopause, obviously, I think you were saying last night, is the absence of a period for 12 months.
Just by definition.
By definition?
Yeah.
Someone starts going through perimenopause or menopause, and then HRT is obviously very popular now, and obviously osteoporosis and has all those benefits. Are there downsides to the HRT conversation for somebody in that element? I'm not talking younger, I'm talking 45 plus.
Yeah, so I think...
Or 40 plus?
I think the way that we've used HRT, has changed quite a bit.
Yeah.
I'd say, so like menopause... at its heart is your ovaries no longer producing the estrogen that you require, and because you're not ovulating, you don't get the progesterone either, but mostly it's an estrogen issue. Your body withdraws from estrogen. So the symptoms you go through are actually kind of withdrawal issues. You get a bit jittery, you get moody, you don't sleep that well, you have low energy, all that sort of stuff, right? It just can be very variable for people of how long it lasts. So we went through a stage where we used heaps of HRT. Everyone loved it. Like in the 80s and stuff, it was used a lot. Yeah. And then they did a big study in America, which was just really misreported by the media when they got hold of the results. And it's not that what they reported was incorrect. It was just catastrophized.
Yes.
So they would say if you're on HRT, you have 7 times the risk of getting breast cancer. Or something like that. So... Which
would be a very scary stat if you're
scary stats. Everyone was just like, oh my gosh. And breast cancer is often the big thing that we pick on. The baseline risk of breast cancer in the population, I think, sits around 12%. So it's actually quite a common cancer that people get anyway. But what they've done over the years is they've broken all of that data down, and they've been able to create risks for little different population groups, and they generally do it by age.
Yeah.
So I'll probably get these numbers wrong. But for example, if you're on estrogen and progesterone for less than 5 years and under the age of 60, your risk of getting breast cancer, you will get, I think it's like maybe 8 extra cases per 10,000 women.
Yeah, okay.
Right. So that's about, close to 1 in 1,000.
Is that the idea with HRT, is that you don't take it forever? You take it for a limited
Well, there's
period
different
of time?
ways that you can kind of manage it. The other thing we've got to be aware of in menopause, 150 years ago, the life expectancy for women sat around 52. Right?
Wow.
Menopause average age is about 51. Once we hit kind of mid-60s, we were getting it closer to kind of 62, 63, 64. We're now like 90, 80, 85, whatever it is at now. So we're actually asking the female body to do a lot more for a lot longer without hormones.
Yes.
And we notice a significant deterioration. Men also go through with hormonal withdrawals over the course of their life, and they lose testosterone. It just tends to happen in a slightly more linear way. They don't have this very specific time that people notice changes, and therefore it tends to be a little bit more sudden. So I would say typically the way that we would have used HRT before would be like, kind of like you'd use Nicorette or Nicobate for someone that's withdrawing from smoking. You say, you're coming off the estrogen, you're getting quite bad symptoms for it. Let's use a little bit of the estrogen the progesterone's just there to protect the lining against estrogen. So if you've got a uterus, you still end up on both. So,
Okay.
But for the purposes of this, I'll just talk about estrogen. You give a bit of estrogen back, and then over time we'll kind of taper it down, just like you would with Nicorette. We'll slowly back that off until we can get to a level, you know, where we're comfortable. So that's probably how we use it most of the time, with an aim that, eventually you'll come off it, because that risk that I said from the 50 to 60 group increases from the 60 to 70 group, increases from the 80 to 90 group. And again, I apologize, I don't know these numbers, but something like 36 per 10,000 in the 80 to 90 group.
So not a
So
crazy,
it does get more likely.
Yeah.
It does get more likely.
But not like
But not stupid. And
yeah.
actually, we used to think it was the estrogen that caused the problem, but actually it's the progesterone that has the higher risk.
Yeah.
So it's the progesterone protective. So then actually, if you've had a hysterectomy and you don't need progesterone, your risk of breast cancer is way lower. It's like it only ever gets up to like 9 or something.
And are we just kicking the can down the road though with the menopausal symptoms? So like if I have gone through menopause and then
Taking
I've
estrogen.
done HRT for, I don't know, 5 years or whatever you're going to recommend to me. And now, you know, we're having a conversation. You're like, okay, let's cycle off that now because of said risks. Am I just going to have another crash, but just a little bit later on?
Sort of, but different. So like part of the reason that menopause can last so long is because the estrogens the ovaries don't stop producing stuff like that, right? They go,
surprise.
and they might do that for years.
Right.
So your symptoms play on for years. Whereas if you kind of cover that period and then as opposed to just withdrawing from it and going through the jitters and everything, you taper that down and slowly lower your dose over the course of 6 months, you may be completely symptom-free when you stop it, or you might stop it and get rebound symptoms. People are different around how they do. And there are some people you end up starting it again when they're like 62 and 63 because they just get all these symptoms after they come off
and
it.
they're just like, I can't deal.
Would anyone ever just stay on it being like, I feel so great now?
Of course
I don't want life to change.
So look, I think there's another way that we use it that's a little different now, that's different to the withdrawal, where they've done some stuff to say if you have two people that are both premenopausal and one of them starts on HRT and the other one goes through withdrawal menopause and then they get down here and they start on HRT again, they never quite get back to the same bone density and cardiovascular improvement that the person who has stayed on it has. So it is more common for people to start on it earlier now so that they don't get the dip off in the downside. So there's lots of benefits that come from HRT. The ones that are quoted most are around bone density and they're around cardiovascular improvement. But there's lots of other things that are less studyable, quality of life, libido, intimacy, feelings of well-being, feelings of womanhood that people have. You feel more. There's a vitality that comes with it.
That's what I was going to ask about.
PB's in the gym, I'm sure, strength and things like that.
Going out to the club,
that's
picking up a
right.
30-year-old bloke when you're 60.
That's right. And if you just think about the fun and joy that would come from an experience like that, we would encourage everyone to get on board.
Yeah.
No, but I think because you lose the blood supply, right? So your muscles atrophy and you start to get, chronic fatigue type stuff and you're tired all the time and you appear older and you feel older.
I've also heard of relationships breaking down and all sorts of things through menopause and stuff like that just because of the difficulty of it and the hormone changes.
Well, I mean, we're talking about menopause as a larger concept now because there is the menopause, which is the physical part that we've talked about, and then there's the menopause as a life transition. And unfortunately, there's a lot that happens around that time that results in stuff like that.
I was purely speaking from a loss of libido, loss of intimacy perspective.
Yeah, but loss of libido and intimacy is not necessarily hormonal.
Okay.
So actually hormones play a reasonably small amount, definitely does, but you've got someone who's dealing with that, usually maybe with a partner that's not that understanding. Their kids have just left home. They're now working out what their role in the world is. Do I want to spend my time without my children in my household with this person? Do I have bigger goals? Oh my gosh, what am I going to do? I need to experience the world. I need to get out. I need to do something else. This isn't me forever. You know what I mean? So there's all of that life transition that happens. And there is certainly some physical stuff like blood supply. Obviously, you just think about the arousal process and how much blood blood supply you get injected into the vulva and the vagina, and just keeping nerves functioning and stuff. There are certainly benefits to having that. But lots of people still maintain intimacy without that. But for couples who are, have a good going sex relationship that they want to maintain, not even couples, individuals, I should say. There are some people who are single who might just do self-pleasure themselves. They don't even have partners, and they still choose to go on estrogen because that's a more pleasant experience for them. It doesn't have to be a couple-related thing. Vaginal estrogen is a pretty easy way to do that. And then there are some more specific stuff that we do around libido.
That's so cool.
And, that can be different types of HRT, and then you can run down the testosterone.
Well, that's what I was going to ask,
because
testosterone for females can be quite beneficial, can't it?
Yeah, but you're still just getting it back up to female levels.
Yes.
People think
I'm not saying super physiological.
you think about doing like this huge thing. But testosterone does contribute a bit to libido, but it's not as much as people think.
Yeah.
Libido is hugely psychological.
I can imagine.
You can imagine, you often have this conversation being like, I just, want to have sex, but it's not happening. I just have no desire. My first question is, do you like him? And they're like, well, yeah, I do. And I said, because
how often do you get that someone coming in a new relationship where they're like, I just don't want to have, like, you don't, right?
That's the joke that we say is like, what's really good at fixing libido is a new boyfriend.
You'd be a hit with all the ladies when you say that to them.
And
they're like, oh, doctor.
But you'd be amazing, right? They're just all of a sudden everything's back. And you think, well, actually it's largely situational. And it's hard for couples that have been in relationships for a really long time because you don't have newness. The thing that old relationships can't do is create newness and spontaneity. And we ask a lot of our partners these days, I want you to be sexy. I want you to be spontaneous. I want you to grab me off my feet, but I also want you to provide for me everything. I want you to do the dishes. I want you to do the kids. I want you to pick this up. I want you to do that. Same both ways, right? I want you to carry my children. You no longer, you got to work, both of you working all the time. You're trying to work out all of that.
It's all the baggage too, right? Like we had a sex therapist on the potty and it's like all of the micro resentments, potential resentments that we carry through a relationship that's been through that many years. It's like all of those things might be sitting in the background, but surely they're going to be affecting the desire to actually be intimate with that person.
Of course, and unless you communicate about it. And the couple of times that I probably do outside of kind of that menopausal libido, the sex counselling stuff is when people are starting fertility, I always have a good chat about it then. And when people are pregnant, and generally the conversation that I will have will be, when we do that first catch up after they had the babies, make sure you always say goodbye to each other when you leave the house and always greet each other politely when you come home. And something as simple like that really changes the dynamic in the household, because when someone disappears out of your house and they don't say goodbye to you, the feeling of loss and just I'm with the kids or other way around. And when people come home and aren't excited to see you, even if you're not having sex and doing all these other things because you're postpartum, if you can maintain a polite, kind tone when you talk to each other and a team-based approach to family life, say goodbye, say hello. It makes a huge thing.
I love that. Yeah. That's awesome.
And most of the conversation I have is a bit about, we talk about, we have this kind of idea of this sexual script as penis and vagina, right? Like that's what sex is, and people get into very little narrow groups. We go to bed, 10:30, you play with my boobs, I roll over, we have sex, you come, we go sleep. And that's what they do, however often they have it. But particularly after kids, but if you look at why we do sex and what we're trying to achieve, most of the time, actually what we want is intimacy.
For sure.
Intimacy is probably more important than penetrative sex, because there are lots of people who can't have penetrative sex due to cancers or injuries or all that sort of stuff, and they still have very good sex lives. And so often what I encourage people to maintain is intimacy. It's actually around how you touch each other, how you help each other, the words you choose when you're talking about each other. And getting into this process of negging or snide comments is terribly unhelpful for anyone. And of course, no one will want to sleep with each other. But like if you can't, you can certainly touch each other. You can cuddle, massage someone's foot. That intimacy is what will separate you from your friends and maintain that close relationship.
Such a good point. And again, with the sex therapist that we had on the potty, she was sort of encouraging couples to look at sex like a menu. It's like maybe penetrative sex is just like one thing on the menu, but there's so many other things on the menu. And, you know, you might not be in the mood for, you know, the steak
course.
and sides, but you might be in the mood for like a little entree over here. And then that's just it for the day or a couple of days or like whatever it might be. It's very interesting.
And I think there are certain groups of populations, and it's probably geared a little toward men, where they don't know how to express intimacy, and because they feel the most intimate when you're having sex, that comes across as I want sex. And so there often gets into this interplay where she's like, well, I want sex. And he's like, well, I want sex. And probably if you could open that up a little bit and you can have a quality conversation, you probably find what he's looking for is connection, actually. He wants to be close to you. He doesn't want to walk around near you in the house. And so then you've just got to work out how you foster that within a couple. You know, what works, what's really nice for you. You know, we put the kids down and you watch that TV because you like that show, and I watch that TV because I go in there. Do some stuff together, man. You know, doesn't have to be anything more than just a foot rub and a tickle and a calf rub and
just a conversation in bed.
Just conversation in bed. Talk before you go to bed, you know.
I like that hello and goodbye thing too, because I think like busy parents, like that it's often like the kids get the goodbye, like have a good day, blah, 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 and they say, you know what I mean? So it's like, I think that's.
Knuckles on the way out. See you, buddy.
Yeah.
See you, mate.
See you in hell. I think I really like that. To bring this conversation, which has been freaking fascinating, by the way, I guess full circle, what are some very basic actionable things people at any sort of hormonal stage of their life, lifestyle-wise, what is the lowest hanging fruit that we can do to maintain good hormonal health?
Good quality exercise program. And I don't mean that because you're in a gym, but I 100% think that exercise fixes or exercise stabilizes a lot of things. And if you can get into something consistent, it just fixes so much of the stuff that you want. You know, like if we talk about the PCOS stuff, it helps manage that. Not even, you know, get back to periods and stuff. Even there is good evidence that that's the case, but it also is great for your endorphins. It's excellent for your mental health. It's excellent for your body image. It gives you confidence. It gives you goals. It means that your job's not the hardest thing you're doing during the day. It just creates, and if you're in a position where you can do group-based fitness, then you also get the community and the social aspect of that, and then you're no longer relying on your partner to provide all of that stuff for you. You get away from screens, you get outside, you get fresh air, your body has to work, your lungs have to expand, your heart has to try, your muscles are sore, and then you do it all again. I just think, like, in general, that has a huge importance. And if you think, so say for the PCOS thing, I think for the pain management, pain and exercise can be really challenging. They're often something that's hard, and particularly people who do have that neuromuscular pain, they need to have advice from a good pelvic pain physio. Pelvic pain physios are pelvic floor physio who have done extra pain. So some people go to pelvic floor physios and they say, oh, I didn't help that much. I would go very specifically to a pelvic pain physio.
Right, okay.
Because their approach to it is very different, and they will give exercises and stuff that are going to be good for where you have particular muscle tension. Like lots of people say, I hurt here in my ovaries, and it's nearly always the obturata internus that they can feel it, but the ovary lies on it, right? But that's what they hurt. So, but they have to have stuff that doesn't make that worse. They've got to get exercise programs that will rehab that particular muscle.
Yeah.
And then I think, when we go back to the libido stuff, there's good evidence that good exercise programs are great for libido. It's excellent for menopause. It's great for bone health. It's great for cardiovascular health. It's great for energy. It's great for sleep. And it's got good evidence that it improves hot flushes.
Interesting.
Well, there's something about when you do exercise for menopause, you want to get hot and sweaty because there's something about the temperature regulation that your body has to go through that then makes it better at regulating those weird spikes. And for period management, I think when you're good in a cycle, be good. Hit your PBs when you're pre-ovulatory. Take that moment. But don't fall into the hole for the second two. The second 2 weeks, you still have to turn up. But you might be 70%.
It might be a bit more uncomfortable, but it doesn't give you an out to just like log on the couch and be like, well, I'm not training.
Yeah. And then for like periods and pain, heat packs, TENS machines, anti-inflammatories are always going to be your best option. Don't be afraid to get in the bath. Water is excellently soothing. They'd be my baseline stuff outside of going down the more medical stuff.
Awesome.
That was super good.
That was so cool.
I love that.
And I'm a big magnesium supplement fan.
Okay.
Get on mag.
Yeah.
It's great for your muscles.
Okay.
Good for your bowels.
At night?
Good for sleeping.
Yeah.
Yeah. There's a brand, I don't know why I'm brand recommending, but there's one called Trimag Restful Night that they do that's got a couple of different types of mag and a few other things in it. And it's like just people, particularly around menopause and poor sleep and just
That's interesting.
sleep is really good. Pre-bed, you get less muscle twitches and stuff like that, and it helps regulate bowel function.
Yeah.
Bowel, sleep, and pain are the few things that they're really good at.
That's really interesting. And with just quickly on that magnesium, is powder better than pills? Is citrate better than whatever else it is? Or are they
I
all
generally recommend magnesium glycinate.
Oh, is it not citrate? Damn.
Well, no, there is citrates.
Oh, good,
But
okay.
I'd recommend a glycinate. Tends to work a little bit better for what I use it for.
Glycinate, okay.
This one's got 3 different types, so it's kind of varied. That's why I like it. Look, some people are good at powders. I like powders, but but if you have bowel symptoms, powders are terrible. They give you diarrhea. So, if that person was using it for a muscle reason, I would recommend a topical spray, probably over a tablet.
Okay. All right.
And
Interesting.
then tablets you got to break down, and I just don't know how much binding agents and stuff's in that stuff. So, but, yeah.
Yeah, cool. That's interesting.
Cool.
Thank you so much, Ben.
Oh my God, this was
very inspirational.
fascinating.
Hope it was
Yeah.
okay.
Yeah.
Thank you.
Pleasure, as always.
Oh yeah.
Thanks, Ben.
Dude, that was so cool. That was like, I reckon that was like our longest potty ever.